This conference will now be recorded.
Assalamu alaikum warahmatullahi wabarakatuh. Are you hearing me? I want to be sure that you are hearing me.
Yeah, you are audible.
Okay. My voice is clear?
Yeah,
Okay.
thank you.
Welcome. Do you see the screen? Now the screen appear for you?
Yes, we can see the screen.
Okay, thank you. Excuse me, it's the first time for me to use the GoToMeeting.
All right. Thank you so much.
To be patient with me.
All right.
Okay, let's start now. Today we are going to talk about introduction and orientation for part 3 MRCOG. First, I wanted to congratulate all my colleague and also my friend who just passed part 2 MRCOG. And I wanted to say that you must be proud of what you achieve, because part 2 is very difficult exam and everyone can pass this exam. But you shouldn't take rest and you shouldn't stop till you achieve your aim by passing part 3 MRCOG. Part 3 MRCOG are easy exam. I think it is easier than part 2 MRCOG, but it needs certain skills, and these skills will be improved by your practice. From today till the day of the exam, you have to practice every day one or two case scenario with your study partner. Try to find your study partner from today. This study partner should be honest for you, and you should be comfortable with this study partner. You also can use or to share with two study partner, because if one is busy, you may study with the other one, but more than two study partner will waste your time. So daily practice will improve your skills and you will make part 3 very easy for you. Today we are going to talk about certain things to prepare for MRCOG, how you will prepare for MRCOG, and what are the module or the tasks you will face in the exam, and in each task what are the domain or the core clinical skills you will be assisted for, What are the type of the tasks that you will see in the exam? How you can use the 12-minute, the 2-minute in front of the cubicle and the 10-minute inside the cubicle, not to waste your time. And at the end, we are going to talk about how you will take history to the most tricky part of the domains. So let's start now by how to prepare for part 3 examination. We know before that part 3 examination is an exam of your attitude and your communication with the patient. But still also you have to know you have to have a good knowledge. If you have a good knowledge, you will enter the exam confident. So you have to revise daily your guideline. Each day you have to revise 1 or 2 guideline, both 15 to 20 minutes for each guideline, and quickly read the guideline. Because this will give you confidence when you enter the exam. So, for example, if you have a case of sickle cell anemia or thalassemia, if you have a good knowledge about sickle cell, you will enter the cubicle confident. But if you forget the information about sickle cell, this will shake your confidence. So revise your guideline. You have now a good knowledge about the curriculum of the obstetric and gynecology. So please don't waste your knowledge. Revise daily your guideline, 1 or 2 guideline, each one 15 to 20 minutes. The second thing, to read the patient information leaflet. It is the simple and the easy way to improve your communication with the patient and improve your lay language. Lay language is the language you will communicate with the patient. You will talk with the patient by this language. You are not allowed to talk with the patient with medical jargon, because the patient will not understand you, and this will be considered as failure of communication. So the patient information leaflet will improve your lay language. It will learn you to say womb inside of uterus. It will learn you to say tummy instead of abdomen, and many words like this. So every day read 1 to 2 patient information leaflet. And as we said in our group, try to record this by your voice. Because you will hear it again and again, and this will fix the information in your mind. So the patient information leaflet is very important part in improving your communication with the patient. The third thing is a study partner. As we said, find from now a study partner, 1 or 2 study partner, should be honest to give you a feedback about your communication, about your patient safety, give you an honest feedback, and should be comfortable with this study partner. Be simple and serious from the start. Simple means that don't compound yourself by much material. If you leave yourself for the groups, you will be lost, because there is a lot of group. All of our group are valuable, but you will be dissociated. So concentrate by one book or one course and study these cases again and again. From my opinion, if you study 100 cases or 120 cases and you keep to repeat this again and again, it will be more better than study 200 cases or 250 cases, because near the exam you will have no time to read all of this, and all the information will be wasted from your mind. So concentrate on 100 or 120 cases and repeat again and again and again. This will improve your skill. This will give you confidence when you enter to the exam. Be serious from the start. This means that you should achieve your aim, and you should finish part 3 examination. Try to make all your life MRCOG, and this by discussing the guideline by your partner and your colleague in the hospital. Try to apply the guideline. Here's the patient information leaflet in your car, or if you have free time during your work. At the end, when you feel that you read all the patient information and you study the case very well, you can take one circuit course, because the circuit course will improve also your communication skills and will put you in the situation that you will face in the exam. you will put yourself in the situation in front of the cubicle and how you will enter the exam to meet the role player or to meet the examiner. This will make the situation of the exam will be familiar with you. Coming to the tasks. In the exam, you will have to face 14 tasks. Each
Doctor,
task
I can't
will
hear
be
your
related.
voice.
You can't hear my voice? Hello?
Voice very clear, yeah.
Okay, thank you. Thank you. Coming to the tasks, in the exam, you will have to go through 14 tasks. Each task will be linked to the 14 module of the obstetric and gynecology curriculum. So you will have teaching task, core surgical skill task, post-operative antenatal care, maternal medicine, management of labor, management of delivery task, postpartum problem, gynecological problem, subfertility, sexual health, early pregnancy, gynecological oncology, and urogynecology. We will talk about each module by this, and each module contain many cases. So we will leave it to later on. So you will have to go through 14 tasks in the exam. In each task, you will be assisted for certain domains. These domains are the core clinical skills. Okay, we have 5 domains: patient safety, communication with the patient and the relative, communication with colleague, information gathering, and applied clinical knowledge. In each task, it is not necessary to find the 5 domains are requested from you. Sometimes it will be only 3 domains, like patient safety, communication with the patient and the relative, and applied clinical knowledge. They will not be communication with colleague or information gathering. But take care that sometimes the communication with colleague can be considered as patient safety. For example, if you have a patient with diabetes and you say that I will refer the patient to the diabetes doctor, this will be considered as patient safety. So, for example, you will stand in front of the cubicle and you will read the paper. It will be written there that this is a simulated patient task during which you will be assisted for. After that, it will be written the domains for example, patient safety, communication with the patient, applied clinical knowledge. It is not likely to have to find the five domains. Mostly, it will be 3 to 4 domains. We will talk about each domain in detail in a moment. Okay, now what are the type of the task? We have 2 types of the task. When you enter the cubicle, you will face either simulated patient or colleague task or a structured discussion task. In the simulated patient or colleague task, you will interact with an actor. You will enter the cubicle, you will find an actor. This actor will play the role of patient or play a role of a junior trainee. Okay, and this actor have a scripted question and they have a detail about the case. For example, if the role player play the role of a patient with diabetes, so the role player have a knowledge about the diabetes and she has a script scenario written in front of her, and she has a scripted question to ask you and to prompt you. So give the patient a chance to talk, give the patient a chance to ask, because it will prompt you. If you forget something, it will help you. So in the simulated patient or the simulated colleague, you will interact with a role player. This role player has a script, okay, and they have relevant data about the patient. But take care of an important point. Sometimes the physical characteristics of the role player not match with the role of that they are playing. What I mean that sometimes you enter the cubicle and you find a young lady, and this lady will play the role of postmenopausal patient, have bleeding, post-menopausal bleeding, for example. So don't concentrate with the age of the role player. Concentrate on the age which are written in the paper, written in the instruction. Another example, you may find the role player are thin, slim role player, but it plays the role of a patient obese, body mass index is 40, for example. So concentrate on what written in the instruction. This is a very important point. You have to concentrate. The physical characteristic of the actor sometimes not match with the role they are playing. Okay, when you enter to the simulated patient task, the examiner will sit there. You will find the examiner sitting in the room. He will not give you any impression at all. He will have mask face, neutral face. So don't look at him at all. You can consider him as he is a fly on the wall, or he is not present at all. Don't look at the examiner at all. Don't interact with him. Even when you enter to the cubicle, don't greet the examiner at all. Concentrate with the patient. Consider the examiner as a fly on the wall, or he isn't present at all. In the structured discussion task, you will enter the cubicle and you will find the examiner waiting you. So when you enter the cubicle and you find only one person inside, so it is a structured discussion task. This is the examiner and waiting you to discuss with you a case scenario. And he have some question to ask you and to prompt you. For example, you may read outside the cubicle. This is a structured discussion task which assists your patient safety communication with the patient and apply clinical knowledge. And he give you a case scenario about patient with pre-labor rupture, preterm pre-labor rupture of the membrane, PPROM. When you enter the cubicle, you will say hello or good morning or good evening according to the time you will have your examination. I am Ali and I am ready for discussion. And sit on the chair. He will tell you that doctor, you are reading, you read the instruction outside. And he will start to ask you, for example, what is the important information you wanted to know from the patient? What is the examination you will do for the patient? What is the investigation? Okay, this is the structured discussion task. So you will enter, find the clinical examiner waiting you. He will ask you a series of questions. Okay, sometimes in the simulated patient task, you find two person or two examiner beside the patient. So this is a clinical examiner and a lay examiner. So you have to concentrate very well in this task because this task will have a great mark. The clinical examiner, he will mark you regarding to the knowledge, like clinical knowledge and the patient safety. And the lay examiner, it is a person come from the general public, have no clinical knowledge at all. He came only to assist you regarding the communication with the patient and the patient safety. He have no clinical knowledge about diabetes. He has no clinical knowledge about the PPROM, but he will see how you will interact with the role player. When the role player cry, what you will do? When the role player become angry, what you will do? So concentrate very well. Try to express all your emotion in this task, because this task will have a great mark. Okay, you may find 3 or 4 cases of the simulated patient task have lay examiner. So in 3 to 4 cases of the simulated patient task, you may find 2 examiner inside beside the patient. So this will be clinical examiner, and the other one is lay examiner. Okay, coming to the domains, the core surgical skill or the domain. As we said, we have 5 domains. You will be assisted in the exam for these 5 domains. First is patient safety. Patient safety is the most important clinical skill. What are the patient safety? How you will assist it for the patient safety? most of the candidate know that the patient safety are the allergy. I will ask the patient about if you have drug allergy, if you have allergy for something, and what about your cervical smear? This is the two patient safety concern. No, not only the patient safety. There's a lot of things regarding to the patient safety. This include the call for help and involving your senior. When you have to call for help and when you have to involve your senior, if you fail to involve your senior in the scenario, which necessitates that you will fail in patient safety. Also, the candidate who involved with the senior in all the cases and he can't take a decision, he can't take responsibility, also can fail in the patient safety. So involve your senior when it is necessary to do so. So when you communicate with the patient, so you may tell her, Mary, I will discuss this with my consultant. If you are in the discussion task, so you have to tell the examiner. You have to tell the examiner that I will involve my senior. I will involve my consultant. This will be considered as patient safety. Confidentiality. As all of us know that the information of the patient and the data of the patient protected by the law, by Data Protection Act, and in each organization there is a person which are responsible for protecting the patient information called the code guardian. So also you have to not to break the patient confidentiality, keep the patient confidentiality, and this can appear in many case scenario. For example, if the patient you suspect that the patient has domestic violence, or the patient come for to need emergency contraception and is young lady, you have to assure the patient about her confidentiality. For example, you can say, Mary, I wanted to assure you that our discussion today is very confidential and no one come to know anything about it unless you want. Even your GP will know anything about this meeting. And in most of the cases and most of the scenario, the role player will not break or will not open directly for you and they say, yes, my husband hurt me and like this. Okay, so you have to again assure her about her confidentiality. Mary, I am here to help you, and I wanted to assure you again that no one come to know about anything. No word will go outside this room unless you want. This is the confidentiality will be considered also as patient safety. The third thing you have to know the duty of candor, and when you have to apologize to the patient, this also can be considered patient safety. If the scenario necessitates that you have to apologize for the patient, for example, if the patient have any complication like shoulder dystocia or third and fourth degree venial tear, and you will go, or the scenario come to debrief the patient or counsel the patient, so you have to start by apologize to the patient. Mary, I'm so sorry for that. I'm so sorry that the care that you find didn't match your expectation. This is how to apologize to the patient. And most of the patient litigation will be relieved by apologizing to the patient. So apologize to the patient will be considered as patient safety. Take a consent from the patient. Very, very important in patient safety to know how to take a consent from the patient, whether it will be verbal consent or written consent. For example, if you will examine the patient after taking the history, thank you, Mary, for sharing this information with me today. Then I wanted to examine you in the presence of chaperone, if you don't mind. Here, you take a consent from the patient. It will be verbal consent to examine the patient. So examination of the patient, you have to take a consent. Also, if you will do instrumental delivery, it will be a verbal consent in the delivery room or a written consent in the theater. Okay, so if you have a case of ventouse or forceps delivery, so you should to mention that to the examiner that I will take a consent from the patient. It will be verbal consent if I am in the delivery room or a written consent if I am in the theater. And sometimes you have a case only case during which you will take a consent during the all case. For example, you take a consent for cesarean section. So you have to discuss the consent with the patient. Mary, I wanted to you to sign here after you will discuss this, that you understand the surgery and what is the intended benefit from the surgery, and you will mention the benefit and what is the associated risk with the surgery, and what is the alternative that I may do during the surgery. This will be discussed later in our cases. Respecting the patient dignity, and this by involving chaperone during the examination. It is very important also to be considered as patient safety. After you finish the history, after you finish history taking, and you will come to examine the patient, so you will tell the patient, Mary, I wanted to examine you in the presence of chaperone. You have to tell this for the patient, if you don't mind. Even in the instruction discussion, you don't have patient at all in the instruction discussion. You will talk to the examiner, and you will come to the point of examination. You will tell that to the examiner like this. Then I wanted to examine the patient in the presence of chaperone after taking her consent. So now you show the examiner that you will respect the patient dignity and you are safe, doctor. Respecting the patient belief and the culture issue, like you have witness, it's very important to respecting this patient. For example, if you know that the patient is Jehovah's Witness, and you know that Jehovah's Witness will refuse a blood transfusion, so you have to discuss this with the patient. For example, Mary, what type of the blood product you will you don't want to have? I will document this in my note. All of this will be considered as respecting the patient belief. Even if the patient die inside the theater, sometimes the Jehovah's Witness will refuse all types of the blood transfusion. Sometimes they will also refuse cell salvage. So you have to respect this. Understanding the UK law, for example, in the female genital mutilation. In the female genital mutilation, when you will discuss with the patient about the operation de-infabulation, and you will inform her that re-infabulation will not done under any circumstances because this will be against the UK law. Also, this will be considered as a patient safety. Very important thing in the patient safety will come in the scenario or in the task of the core surgical skill, the WHO checklist. You have to tell that for the examiner. When you will talk to the examiner, and now you will enter to the theater, so you should to tell the examiner that I have to do WHO checklist. This will include sign in, time out, and sign out. Checking the patient allergy, as we all know that checking the patient allergy will be considered as a patient safety. So before any drug, you will give the patient to sure that the patient don't have allergy to this drug. Even in the history, when you are taking a history, for myself, I taking this allergy for all of the patients. So I put it in my template, asking about allergies. So ask the patient, do you have any allergies at all? Not only for the drug. Sometimes the patient may have allergy to the latex. So ask here open question, do you have any allergies at all? This will be considered as patient safety. Excluding pregnancy before certain surgery like a hysteroscope, as all of you know, this will be considered as patient safety. How to prioritize the patient and how to triage the patient will be considered as patient safety. There is a scenario will may come in the exam, and it came in our exam already, about labor room prioritization. We give you a 7 or 8 scenario for patient in the labor room, and he tell you how to prioritize this patient and what you will do. So prioritizing the patient and knowing which patient you will start and what you will do, this will be considered as a patient safety. And we will talk about this and how to know which patient you will go directly and which will be the first case. We will know this in our discussion later. Okay, the second domain is the communication with the patient and the family, and it is very, very important domain. No one can pass the exam, he will fail in communication. And even if you don't know knowledge about the patient, about the scenario, about the case, and you have a good communication skill, you still can pass in this exam. And I remember in my exam, I have a scenario with thyroid disease, patient with thyrotoxicosis, and unfortunately, I didn't study this the thyroid gland before my exam, and I find the case inside the exam, and I forget what we will do for this patient. But because I practice very well, and I bought a tablet for myself how I will take a history from the patient in the antenatal period, and what I will tell her, what we will do during intrapartum and postpartum. So alhamdulillah, I pass. So if you can communicate well with the patient, and even you don't have enough knowledge, you can still pass in this task. Okay, communication with the patient. When you enter the exam, or when you enter the cubicle, how you can make a rapport with the patient? Okay, by introducing yourself and your role to the patient. Hello, I am Dr. Ali, one of the senior doctor in the clinic today. May I confirm your name and age, please? By this method, by this, you will make a report with the patient. You may also make a smile, a large smile in your face, and enter the cubicle confident from yourself and calm. This also will make a report with the patient. But take care if the scenario is breaking bad news, or you will give a bad information or bad result to the patient. Here, making a smile will not be suitable for the patient. So if the scenario is suitable, you can enter the cubicle with a smile. Hello, I am Dr. Ali, one of the senior doctor in the clinic today, or in the duty today. May I confirm your name and age, please? This is you from the first moment you make a rapport with the patient. Then breaking the ice and between you and the patient by checking her expectation and the concern. For example, Mary, I understand a few years later that you are here today to book your pregnancy. Any other expectation or concern you want to add? This is your break, and let the patient to talk from the first moment. This will give you also a good impression. Body language. Body language. Be active listener to the patient is very important. Very, very important. When the patient speak, you have to listen to the patient, and you have to show that her that you are happy to listen to her. This can be made by making some encouraging sound like or making a nodding of the head and maintaining eye-to-eye contact. This will give impression about you that you are active listener and you are happy to listen to the patient. It's very, very important. So you have to practice this with your partner. And if you don't have a partner, you can practice this in front of mirror. Show empathy and appropriate emotional response when it is necessary. For example, if the patient cry, if the patient become tearful, in this situation, you have to pause at all, stop talking at all, let the patient cry. Even if the patient cry that during the 10 minutes, you have to let the patient, let her, but show empathy on your face. And after that, you can give the patient a tissue if there is tissue, asking her, are you okay? Can we continue our consultation? Do you want to call me? Do you want to call someone to be with you now? This will give a good impression about you in the examination. Be non-judgmental while dealing with a patient, a concern or decision, and this means that you don't you shouldn't tell the patient that you have, I decide, I see. This or not will be accepted from you. You have to tell the patient that we have many options. I will discuss this with option of with you, and at the end the decision is yours. By this method, you show that show the examiner that you are not judgmental, and you involve the patient in the decision, and you are respecting the patient autonomy. Give the information in a small amount, and this means that you shouldn't talk a lot, and give the patient a lot of information. The patient may be dissociated from you. She I not understand what you say. So give the patient a short information, then ask her, are you following me? Am I clear? Then continue your discussion or your consultation. Okay, so give the patient information in a small amount. And as I said, checking understanding. Are you following me? Is it clear for you? And encourage the patient to ask, do you have any question? This will give you a good impression that you're involving the patient in the consultation. As we said, respecting the patient autonomy is very important in communication with the patient, and it will be shown in the patient coming, for example, asking about a certain place of delivery, like home delivery, and she has a previous one cesarean section. You shouldn't tell the patient that no, you have to deliver in the hospital. It is be risk for you. This not respecting the patient autonomy. The patient has to do what she wants, even if it against the medical advice. So respecting the patient autonomy and negotiate with the patient. Negotiation with the patient is a skill. So you have to tell her, Mary, I am here today to give you all the information that you need, and I will try to address all your concern. At the end, the decision is yours. So start by the option that she choose, and take the patient to your side by saying, Mary, home delivery is a good option because you will be surrounded by a lot of people that you know, and you will deliver your baby in a calm place. But I am sorry, it will be not suitable for you because 1, 2, 3, 4, and after that. So you gain the patient to yourself by saying, yes, home delivery is a good option, but so this is a skill of negotiation. Avoiding the jargon, very, very important. Don't tell the patient or don't talk to the patient by medical language at all. The patient will not understand you, and she may dissociate you and ask you, doctor, what does this mean? Doctor, what does the uterus mean? And you spend a lot of time to think about what the uterus, what is the uterus, what is womb. So this all will come from the patient information. So you have to read the patient information very well. Appropriate signposting, sometimes you have to signpost for yourself. For example, if the patient, you see that the patient is very anxious or the patient is very angry about something wrong, so signpost for yourself. I totally understand that you are anxious. I can see that you are angry. This is how to signpost for yourself. Signpost will take the patient to your side. Is my voice clear? Hello?
Yes, clear. Your voice is clear.
Yeah, your voice is
Yes.
very clear.
Okay. Coming to the communication with colleague. Mostly it will be assisted in the instruction discussion task, and also may be assisted in the simulated patient task, but mainly in the instruction discussion task. In the simulated patient task, as we said before, it will be considered in the patient safety. For example, if the patient have diabetes, if the patient have sickle cell disease, and you say that I will involve the blood doctor, I will involve the diabetes doctor, this will be considered here as a patient safety. But it will be pure communication with colleague in the stimulated in the structured discussion task. How you will communicate with your colleague? This involves the senior help. As we said before, we can involve our consultant, involve our senior. You have to mention that to the examiner when the scenario involving the consultant. The multidisciplinary team, very, very important in certain situations to mention the multidisciplinary team. For example, if you still have the patient of diabetes or sickle cell disease, you have to tell the patient that if you are talking now to the patient in the simulated patient task, Mary, your care will be under group of doctor. This is the lay language of the multidisciplinary team. your care will be under group of doctor, which include the diabetes doctor, dietitian, and don't forget the specialized nurse, the diabetes nurse. This is what I mean by multidisciplinary team. So it will be group of doctor. If you are in a structured discussion task, so you will tell the examiner the care of the patient will be under multidisciplinary team. This will be communication with the colleague. The SPAR tool. It is a method of communication between doctors and or between you and your consultant, and in the handover process when you are now you will there is a new doctor coming to the new shift, and you will endorse the patient for the new doctor. So apply the SPAR tool. So in the simulated patient task, when you are talking to the examiner, and you will tell the examiner that I will communicate with my consultant, tell him that I will communicate by the SPAR tool. What I mean by the SPAR tool, SPAR mean S for situation awareness, B for background, A for assessment, and R for recommendation. What does I mean by this? For example, if you have patient with PPROM, premature pre-labor rupture of membrane, and she came in 33 weeks with a leak in the ER, you will apply the SPAR tool by communicating to the neonatology doctor. You will involve the neonatology doctor because she is preterm. So you have to know whether there is a cot available in your hospital or no. So I will communicate with the neonatologist or the neonatology doctor or the baby doctor if you are talking to the patient. By the SPAR tool, I will tell the doctor that I have patient with PPROM, preterm pre-labor rupture of membrane. This is situation awareness. This is situation awareness. Start by the situation awareness. I have patient with pre-labor, preterm rupture of membrane. What is the background? For example, she is primary gravida, and she in her 33 weeks, no medical history and no surgical history. And assessment by examination, the abdomen is soft lax and the fundal level is equal to 33 weeks. And by vaginal examination, there is a leak, the cervix is closed. And assessment also include investigation. If you did for hair ultrasound, if you did for hair a fetal fibronectin test, you should to mention. This will be in the assessment. And your recommendation at the end. I recommend to admit this patient for corticosteroid, for example, for antibiotic, for example, like this. This will be the SPAR tool. Very, very important in communication with the healthcare professional. The last thing in the communication, it is the teaching session. It will be included alone in a lecture, inshallah. Applied clinical knowledge, as we said, you have now a good knowledge about the curriculum of the obstetric and the gynecology, and you shouldn't waste this knowledge. Please try to revise the guideline, 1 or 2 guideline each day, 15 to 20 minutes for each guideline. Quick read the guideline, not to waste your knowledge. How you will assist it for the applied clinical knowledge in the exam? This will be included or shown by justifying your investigation and the intervention. When you will say to the examiner, I will do, for example, ultrasound. Ultrasound for what? You have to justify. Ultrasound for to see the gestational age, to see whether this is multiple pregnancy, to see whether the placenta localization. You have to justify. For example, if you have patient with hyperemesis gravidarum and you tell the examiner, I will do from the investigation, I will do ultrasound. Why the ultrasound? Because I wanted to exclude molar pregnancy. I want to exclude the multiple pregnancy to check the viability and the gestational age of the patient. So you have to justify, not mention only. If you mention only, you will not take the mark. You have to justify. Justify your intervention, yes, justify your investigation. Also, applied clinical knowledge will be assisted by interpreting the clinical finding and the result of the investigation. Sometimes in the paper there will be a lot of paper in the case scenario, including the history and the investigation. You have to pick what is the abnormal investigation and to interpret this according to the case scenario. Discussing the management option, as we said, we have to discuss the management option. The management option with the patient will be also assess your communication applied clinical knowledge. Okay. Present a balanced view of risk and the benefit of any intervention. You have to know what is the benefit of each intervention and what are the risks of each intervention. Okay, for example, the patient wanted to have a home birth and she had previous cesarean section, so you have to tell her what is the benefit and the risk. The patient had previous cesarean section and she came now in the antenatal period and discussing the mode of the delivery. So you have to tell her that we have two options, either VBAC or elective repeated cesarean section, and you have to know the benefit of this and the risk of this, and the benefit of the elective repeated cesarean section and the risk. This will assist your applied clinical knowledge. The most tricky domain is the information gathering, how you will take information from the patient and what is the information you will take from the patient. You have to know what is the information and how I can take this information. First, you have to make a template for yourself. At the end of our lecture today, I will put a general template for all of you. You can make your own template. Don't ask irrelevant question, and this by putting a differential in your mind. If you ask all the question coming in your mind, you will waste your time and you will finish the information gathering in 10 minutes. So you will not do anything other than information gathering. So you have to ask a relevant question by putting a differential. When you read the instruction outside the cubicle, so put differential in your mind. So I will ask 1, 2, 3, 4 in the history. Information gathering or history taking is an art, so you have to practice this, not to waste your time. Okay, please ask open question rather than closed question, because open question will not waste your time and will give the a chance for the patient to talk. For example, if you ask about for example, if the patient came with bleeding or pain, don't ask her what is the color, what is the amount of the bleeding, what is the type of this pain. No, tell her, could you tell me more about this bleeding? Could you tell me more about this pain? She will say this bleeding is a large amount. For example, it came every month. It came like this. She will talk. She will talk about the pain. She will say this pain like colic pain, and I feel it, for example, after and increase by and decrease by. She will talk. And if the patient forget to mention something, ask a closed question about this thing that she forget to mention for you. So ask open question. Make your information gathering mainly open question, and don't repeat the question, because repeating the question give the impression to the examiner that you are not listening to the patient. So don't repeat the question, and be sure that the patient will not misdirect you at all, and she will not give you incorrect information. No, it will give you correct information, and she will lead you and prompt you. All the role player want you to pass, and she wanted to help you. So please concentrate with the role player. Concentrate in the answer. Don't ignore cue from the actor. Very important thing. Very important thing. When you concentrate with the actor or with the role player, she will prompt you and she will help you. If the patient, for example, is not looking at you at all, or she look down, or she make any strange behavior, she wanted to tell you something. She wanted to tell you, doctor, stop taking history. That's enough. If there is a hidden agenda, you have to ask. So concentrate with the patient. Sometimes it may be domestic violence, and you are wasting your time in taking obstetric history, gynecological history, family history, and there is this case is domestic violence. You don't have to mention all of this. You have to assure the patient about her confidentiality. You are here to help her and put a plan for this. So don't ignore the cue from the actor. Relevant examination and investigation. When you finish information gathering, when you finish history taking, this not only the information gathering. Information gathering also include examination and relevant investigation. So please don't forget to, after taking history, you will say to the patient, now Mary, I wanted to examine you in the presence of chaperone, if you don't mind. And that's not enough. You have to say what you will do. I wanted to take your pulse, blood pressure, and temperature to be sure that you are in best possible shape. And I wanted to examine your tummy for 1 to 3. I wanted to examine you from down below for 1 to 3. This is how to take information from the examination. So you have to justify. If you said I will do examination, you have to justify what you will do and why. And also the investigation. Mary, I wanted to run some tests for you. This will include CBC4, and I wanted to do a blood test for, I wanted to do ultrasound for. So this also will be considered in the information gathering. Okay, try to take information gathering all of this in 3 minutes, not more than 3 to 4 minutes, because the time is only 10 minutes. So you still have you will still have time to discuss the management option for the patient. Okay, now you are in front of the cubicle and you are going to read the instruction outside. You have 2 minutes. In front of the cubicle, you have 2 minutes only to read the instruction written in the paper. Sometimes it will be only 1 paper. Sometimes it will be 2 paper. Sometimes it will be 4 or 5 paper. In my exam, there is, I think, 2 or 3 cases. There are 4 to 5 paper. You have to go through this paper. So read the instruction carefully but rapidly, and write down the important information. Like what? Like the name of the patient, because you may forget the name, and if you say the name wrong, so it will be a failure in communication with the patient, will give you a bad impression, will give the examiner bad impression. Write the name of the patient by big letter, Write the place where you are now. You are now in the gynecology clinic, you are now in the ER, you are now in the antenatal clinic. Write this, okay? Write what is expected from you. For example, you will have you will read the paper. Now you are this is a structured discussion task. You are assisted for patient safety, information gathering, and apply clinical knowledge, and he will give you the scenario. And after that, you have 10, they will be written there that you have 10 minutes during which you are expected to take a history from the patient, discuss the management option, exploring the patient concern. So write what expected from you, not to miss any point. Okay, and write what you will do inside, not all the things sure that you will do, but the important thing. For example, this case, I have to ask about for example, the HRT. I have to ask about the history of blood clot. I have to ask about the breast cancer. I have to mention that we have a medical treatment, non-medical treatment, cognitive behavior therapy. So write the important thing by big letter. Okay, this is what you will do in the 2 minutes outside the cubicle. Now we enter to the cubicle, and you have 10 minutes to interact with the examiner in the structure discussion task, or with the role player in the simulated patient task. So when you enter the exam, the first impression always lasts. So you have to look calm, confident, competent, smile to the patient, as we said, if it's appropriate. Show the examiner that you are safe and competent doctor. Try to show this to the examiner that you are safe doctor, competent doctor. Sometimes you may face a difficult task, as we said before. Difficult scenario. You didn't finish reading the paper outside. You don't know what is the scenario. What is this? You still can pass in this scenario. You still can pass in this by communication with the patient and by showing the examiner that you are safe doctor. You still can pass in this scenario. Just be yourself as you are sitting in your clinic. Talk slowly to the patient, not too rapid. Make a good eye-to-eye contact. not pass in the instruction sheet too often. When you enter into the cubicle, either in the simulated patient task or the instruction discussion task, you will find the instruction written outside the cubicle there in front of you on the desk. It will be fixed on the desk. So you may have a look in this instruction if you forget the name, if you forget the age, the blood group, if you forget some point, but not often, not too often, because this will dissociate and will break the eye-to-eye contact with the patient. Okay, don't use medical jargon at all. As we said, use lay language and listen to the role player. When the patient talk, don't interrupt her at all. Even if she talks 3 to 4 minutes to talk, listen to her and make nodding of your head that you are happy to listen to her, making encouraging voice like okay, this will give a good impression. Okay, also don't be panic if you have a difficulty station and you didn't do well in this station. Still there is 13 station. There is 13 station. You will prove yourself and you still can pass this exam. In my exam, the first scenario I face was VIN, vulvar intraepithelial neoplasia, and this scenario I know by my heart, and I studied it very well before the exam. But because of the stress affected my nerves, and this was the first scenario, and was the first case in my exam. It affected my behavior inside. Even when I enter the cubicle, I forget what I will start, how I will start. I forget, and the role player try to prompt me many times. So please don't be panic. Don't allow the stress to affect your nerves. Be calm. You can pass the exam. If the examiner didn't give you any instruction at all, didn't give you any impression at all, he is instructed to do so. You can imagine the examiner in the simulated patient task as a fly on the wall, as we said before. Sometimes the role player may be angry or depressed or irritated. She has instruction to do so. So don't say that why the role player do this with me. I make something wrong. No at all. She has instruction to do so, to know what you will do when the patient become angry, how you will interact with this. Okay. Avoid common error done in the examination. If the examiner asks you, for example, what you will do for this patient in the instruction discussion task, so tell him what you will do, not what is later in the literature. And if he asks you what is the common side effect of, for example, of any intervention, tell him the common. Don't tell him all the complication, because this will give a bad impression about you, that you don't understand the question, or you don't understand the case. He asks you about the most common side effect, the most common complication. So tell him the most common, not everything. Okay, so be concise with the question. Answer only the question that given for you. Don't jump to any following information. Okay. Now we are coming to the general sheet. You can make a template for yourself, and my advice is to write the scenario or the cases that you study. For example, I said before that you have to study 100 or 120 cases and repeat them again and again. And better to write these cases, write in a paper. This is my advice. Other colleague don't prefer this. Okay, but I prefer to write, because writing when you revise the case again, you will know what is the information you missed. You will write this. Sometimes there is a knowledge you will know more about what you write. You will add this. Your study partner will give you more information. You will write this in the case. So write, and before the examination, you can read all of this. Okay. Okay. This is a general sheet. What you will do when you will enter to the cubicle, I will greet the patient by saying hello or hi or good morning, good evening, anything of greeting, and introduce yourself. I am Dr. Ali, one of the senior doctor in the clinic today. Confirm the identity of the patient. May I confirm your name, please? Okay, so greet, introduce, and confirm the identity of the patient. Hello, I am Dr. Ali, one of the senior doctor in the clinic today. May I confirm your name and age, please? Some may prefer to say to the patient, how would you like me to call you? And some may not prefer to do this. Okay, no need. She will say, for example, I am Sarah John. So, hello, Sarah. Okay, greet, introduce, and confirm the identity. Hello, I am Dr. Ali, one of the senior doctor in the clinic today. May I confirm your name and age, please? Check the purpose of the meeting. Okay, I understand that you are here today to book your pregnancy. Understand that you are here today because you have pain in your tummy. Understand that you are here today to discuss the result of the test. This is the purpose of the meeting. Checking expectation and the concern. What do you have any other expectation and concern? Because if you forget something by asking this question, you are safe. Okay, the patient will tell you, yes, I wanted to discuss 1, 2, 3, the management or the management option for me. So you have to ask about any expectation or concern. Then put agenda for yourself. For example, okay, before we'll discuss the best management plan for you, I wanted to ask you some question to know more about you. Let me examine you the presence of chaperone, if you don't mind, and I may run some tests for you. At the end, we will discuss the management. This is an agenda. You have to tell to the patient in the start of the consultation, because if the time run and you didn't do examination or you didn't discuss the management option, at least you mention it in the start. So putting agenda in the start of your consultation. Then go to the analysis of the present history. As the general sheet we already know. Analysis of the complaint. If the patient came with pain, for example, so could you tell me more about this pain? May I understand that you have pain in your tummy. Could you tell me more about this pain? Ask open question. Okay, she will tell you, yes, this pain starts since, and it is colic pain, increased by, decreased by. Okay, ask any relevant symptoms about this, about her complaint. Do you have any bleeding? Do you have any discharge from down below? How do you appreciate your baby movement? Like this. This is analysis of the present illness. Coming to the obstetric history. In the obstetric history, we have a current obstetric history and the past and the future obstetric history. In the current obstetric history, you will ask the patient, if the patient came, for example, in the antenatal period, so ask her, is it your first pregnancy? She will say, for example, yes. Okay, go to the second question. Is it planned pregnancy? She will say, for example, yes, congratulations. This is a communication with the patient. This communication. If she said, no, it isn't planned pregnancy. It isn't not planned pregnancy. So you have to ask her, are you willing to continue with this pregnancy? Are you happy to continue with this pregnancy? Okay, from the first question, if the patient said, no, it isn't not for my first pregnancy. Okay, could you tell me more about your previous pregnancy? This is an open question. Could you tell me more about your previous pregnancies? She will tell you, yes, I have 3 pregnancies before. I have 2 miscarriage and 1 term delivery. It was normal delivery, and like this. If she forget to mention something, ask specific or close the question. How was your delivery? Like this. How is your baby? Ask, close the question after the open question. This is the current to the current pregnancy. Okay, ask about any scan done in this pregnancy, any test done in this pregnancy, any problem so far. All of this in the current pregnancy. In the past, is that, as we said before, could you tell me more about your previous pregnancies? She will mention for you about her pregnancies. If the scenario necessitates to ask her about the future pregnancy, did you complete your family? What is your plan for future pregnancy? She will mention. For example, if you counsel a patient with fibroid and there are different options like myomectomy or embolization, hysterectomy. So you have to ask this question. Did you complete your family? What is your plan for future pregnancy? Coming to the gynecological history. In the gynecological history, there are 3 things you have to ask about. Ask about the period and the smear and the contraception. Ask about the period. Could you tell me more about your period? When was the last one? And when you ask here, could you tell me more about your period? It will save your time, because she will say, yes, my period is regular and she is 28 days and she is normal amount and okay. If she forget to mention something, ask close question. Could you tell me when was the last one? Okay, ask about the cervical smear, and this will be applied for the patient 25 years and all and more. So don't ask about the cervical smear in younger patient. Okay, could you tell me more about your smear? When was the last one? Okay, was it normal? Okay, this is you ask about the cervical smear. In some scenario, may have to ask about the contraception. For example, are you use any contraception right now? Did you use any contraception before? In some scenario, asking about the medical history. This by saying, okay, are you following your GB for any medical problem at all? She will say, yes, I have, for example, diabetes, and I go to my doctor. The last consultation was. If she forget to mention any point, you have to ask in close question. Surgical history. You will ask about the surgical history by asking the patient, do you have any surgery in your tummy or pelvis or down below? She will say what if she has any surgery before. Drug history. In the drug history, you will ask the patient about, do you use any drug right now? Do you have allergies at all? Putting the you can put the allergy in this drug history. Do you have any allergies at all? If the patient early in the antenatal period, you have asked her about the folic acid. Do you use folic? Okay, this is regarding to the drug history. The social habits, smoking and alcohol and recreation drug. Some doctor or some candidate may prefer to signpost before this question, and the other don't prefer to signpost. Signpost by telling the patient, sorry if you find my question intruding. Do you smoke? But smoking is already a regular habit or normal habit in the UK. So from my opinion, you don't have to signpost for yourself by asking about this. So you can ask directly, do you smoke? If she said yes, how many cigarettes per day? Is it regular cigarette? Because sometimes it may be not regular cigarette, maybe marijuana or anything else. Okay. Alcohol. Ask about alcohol. Do you drink alcohol? How many unit? If she said yes, how many unit per day? Ask about recreational drug. Do you use any street drugs? Okay. And if she mentions that she is a smoke and alcohol or recreation drug, you have to mention that you advise the patient. Here came your job to advise the patient. Have you ever think to quit smoking? She said, for example, yes, doctor, but I tried many times, but I failed. Okay, give her some risks of the smoking. For example, Mary, smoking can affect your health and your baby. Your baby may be smaller than expected, and you may have also a lung problem. Like this. Not to mention all the side effect of smoking, not all the side effect of alcohol. Mention one or two because the time would not allow you. So, have you ever think to quit smoking? If she said yes, doctor, but I've tried many times, but I failed. So now you have to tell her Mary, smoking can affect your health and your baby. Your baby may grow smaller than expected, and you may have a lung problem. If you wish, I can give you NHS stop smoking service. They will contact you and offer help. NHS stop smoking service. You have to give this for the patient. NHS stop smoking service. Okay. Coming to the social history. In the social history, you'll ask the patient about her job. What do you do for a living? Mary, what do you do for a living? Okay, ask about her partner. Are you with someone right now? Ask about or exclude domestic violence. Is he supportive? Do you feel that you are a happy couple? Only one question is enough. Is he supportive? She will say yes. If she started to think or said, look away, it give you a cue. It give you a hint. She give you a hint about there is a hidden agenda. It may be domestic violence. So you have to stop and stress on this point. Stress on this point. Mary, I wanted to do you wanted to tell me something? Are you okay? I wanted to assure you that our discussion today is very confidential and no one come to know anything about it unless you want. Sometimes it will be domestic violence. Okay, this is the social history. What do you do for a living? Are you with someone right now? Is he supportive? Okay, this is you cover the social history. Then coming to the psychological history by asking it the two whole question as per NICE guideline. For every patient during pregnancy and the postpartum period, you have to screen for the psychological problem by asking the two whole question. Mary, during the last 4 weeks, have you been bothered by feeling low? During the last 4 weeks, have you been bothered by loss of interest in doing things? She will say, no, doctor, I'm okay. I'm happy that I am pregnant now. She may say, yes, doctor. If she said yes, do you feel that you need help regarding this? I can refer you to a doctor, specialized doctor, and you will talk. Okay, this is regarding to the psychological history. Coming to the family history, you will ask the patient, do you have any family history of medical concern? Do you have any family history you wanted to tell me? She will say, for example, yes, my mother is diabetic, my father is hypertensive, my mother has the blood clot, my father has a clot in his heart, like this. Okay, do you have any family history of medical concern you wanted to tell me? Okay, after finishing the history, don't forget to ask the role player if she wanted to add anything, because by this question you are safe. If you forget to ask about anything, she will tell you. She will mention that for you. Mary, do you want to add anything for me? She will say, yes, doctor, I wanted to tell you that I have clot in my leg last year. Oh my God, I forget to ask about the medical history. So this is very important when you will counsel a patient, for example, for the or contraceptive or hormonal replacement therapy. So you have to ask about this question. It's very important. Do you want to add anything for me? Okay. And at the end, don't forget to thank the patient for sharing this information. Thank you for sharing this information with me today. Now, Mary, I want to examine you in the presence of chaperone, if you don't mind. I want to examine 1, 2, 3. I want to do some test for you. This will include 1, 2, 3. This regarding to the general sheet. Sure. In the urogynecology module, there is a different sheet. There is some modification in this sheet. And in the sexual module and the self-fertility also, there is a modification in this sheet. We will talk about this inshallah later on. Today we finish our lecture today. If anyone of you have any question, we can start open discussion. Okay. Do you have any question?
Hello, good
Yes.
afternoon.
Good
I would like
afternoon.
to, yeah, I would like to know that this psychological history, you told one we can ask about the postpartum patient, and if patient is already psychic patient, then we can ask also. And what else?
What else?
Yeah, any others
Yes.
that can ask?
Most probably the psychological history will take during the antenatal module when the patient came in her pregnancy or in the postpartum module.
Okay.
This is a time when we will screen for the psychological problem as the NICE guideline recommend, asking the patient the two whole question. During the last 4 weeks, have you been bothered by feeling low? During the last 4 weeks, have you been bothered by feeling loss of interest in doing things? If she said no, okay. If she said yes, do you feel that you want help regarding this? We have here in our hospital very experienced person. You can talk with him. He is the counselor, and after that we can refer you to the mental doctor or a psychological doctor.
Yeah. So no, my question is all antenatal patient we have to ask this patient this question.
Yes, better.
All antenatal
Yes,
patient. Right.
yes, better
Okay.
to ask for all antenatal patient to be safe, because if you forget and there is a hidden agenda, you will put yourself in a trap. So please, for every antenatal patient, ask the patient about this psychological history.
Right. And breaking bad news, like, if there is a patient coming, the cancer patient, so is it better to, the ask only the relevant question, relevant history? Because,
Yes,
if I ask all history, then I'll miss the, important information, isn't it?
yes, yes. In the breaking
Mm,
bad news, you will find outside. You will not find the information gathering in the domains.
mhm,
You will not find that. If you don't find information gathering in the domain,
mm,
suspected that you will have drama inside this scenario. So
right,
you will prepare yourself for the drama. Prepare your tissue and you prepare yourself for the
right,
patient will cry and like this. So if you
right,
didn't find the information gathering outside the cubicle in the instruction paper, so prepare yourself. There will be a drama inside this cubicle. So for example, it will be breaking bad news, angry patient, counseling a patient after IFD, like this. Okay, angry husband, for example. So there it will be a drama. So you have to take a relevant question, asking only a relevant question. Sometimes
yeah,
the patient will not give you time at all to ask a question, and she will say, doctor, can you tell me what is the result of the test? You have
mhm,
to, you may tell her, okay, I will, can I ask you some I will come in moment to discuss this with you. Can I ask you some question to know more about you first? She will say, no doctor, I wanted to know now. Okay, now you can give her directly. By the system, we will talk about breaking bad news, how you will signpost, and how you will give the first the first warning sign and the second warning sign, and how you can make silence after that, and then give time to the patient to express her emotion, and after
mhm,
that you will explain the thing for her.
right.
Okay,
Yeah, thank you very much. Thank you.
welcome, Dr. Salma. Any other question? Okay, thank you. Inshallah, we will prepare another lecture, another session for discussing the cases and the scenarios of the early pregnancy. Inshallah, we'll postpone in the group and we'll decide the time. Inshallah. Thank you.